Today, your moderator is Dr. Frida Moore from Africa Healthcare Network, and I will introduce the speaker, but I'll just want to put some things in order. Please remember to mute your mic as you enter. And another thing, if you have any question, any comment, don't hesitate to write them on the chat box or question and answer, and they will be attended at the end of the presentation. If you want to talk, you can use the raise hand command at the bottom of your screen. Then you'll be given the chance to comment or to talk and add on the presentation. Okay, I think it's time to start. And again, I would like to welcome you to Africa Healthcare Network Fireside Chat series number 78. And today we are going to talk about understanding the approach and techniques for the permanent vascular access in hemodialysis. Our presenter today is a consultant vascular senior surgeon from Rochester, New York. Also, he's in American Board of Surgery, certified in surgery and certified in vascular surgeon. He has attended medical school in Drexel University of College Medicine in Philadelphia, Pennsylvania. Also did his residence in Pennsylvania and fellowship in Eaglewood Hospital, New Jersey. So I would like to welcome Dr. Jerry Svoboda to take us through the presentation. You are welcome.
Well, thank you very much for that very kind introduction. I'm honored to be asked by Dr. Vincent to give this presentation. This presentation was designed to teach vascular surgeons, rather to teach general surgeons. So an orientation really to a wide variety of people who may come from a wide variety of trainings to know what AV fistula is. So some of this may seem extraordinarily simple some of this may sound extraordinarily simple to some of the attendees, but there'll be some technical information here that may be of interest. And if you could show the first slide, please. Lloyd, I believe, has the slides. Most of us know what an AV fistula is. It's a surgically created connection between artery and vein to divert rapid blood flow into a superficial channel, usually a vein. When it's made with only natural materials, the artery and vein, of course, we call it an AV fistula. If a prosthetic vascular graft is used, it's called an AV graft. And AV grafts are in still having a fair amount of use in the States. There's a difference, of course. In an AV fistula, the vein should slowly enlarge or mature, and it can be used when it's about the size of a pencil. By the way, all participants are not expected to agree with everything that I say, and that's fine. And I'd be happy to have any comments or questions. So it's a lot of fun for me, actually. In an AV graft, of course, the punctures are made directly into the graft through the skin. So no maturation period is needed, and the use of an AV graft can usually begin earlier than an AV fistula. Nephrologists taking care of dialysis patients all know about needle sizes, and this picture is to orient. Let's go ahead with some pictures, please. Next slide. So here's the difference between an AV graft and an AV fistula. No maturation period needed with the graft. Next slide, please. And here's a picture of various needles used for hemodialysis in AV fistulae. Smaller than 18 gauge is not used, and larger than 14 is not used either. And for people unfamiliar with these sizes, as some of my student surgeons have been, a 19 gauge needle is 1 millimeter in diameter, and a 14 gauge is 2 millimeters in diameter. Also, we hear some other terminologies here. An AV malformation is a naturally occurring, usually congenital connection between an artery and vein. Some people use this terminology only for CNS lesions, but most vascular surgeons use it for a naturally occurring connection anywhere in the body. The term AV fistula can also be an acquired condition, sometimes iatrogenic, related to penetrating trauma. Why would one want an AV fistula? Well, nephrologists know the answer to that, but to tell my surgeons, a successful AV fistula allows repeated large bore needle access by the non-physician for hemodialysis. Here's some examples of AV fistulae, because some of my students don't know what a mature AV fistula looks like. In the right lower slide, you might wonder, is that a very cooperative vein or graft? It's the forearm. And one way to tell, I mentioned to my students, is to look for the number of scars. If there's only one scar, it's an AV fistula. If there are two scars, it could well be a graft. The ideal AV fistula is uncomplicated outpatient surgery, matures to useful dialysis in less than 2 months. We all know the rule of sixes, so even 6 weeks, God forbid, and provides flow rates of greater than 350 ml per minute. And of course, someone who's responsible for hemodialysis ordering would like that flow rate to be 800 or greater. We don't want our fistula to occlude. We want it to be cosmetically acceptable to the patient. And certainly we want to have adequate distal limb blood flow. So we don't want an ischemic hand or foot to worry about or to bother the patient. We also want the nurses to be able to hit the target easily. Historically speaking, the first successful dialysis was in the Netherlands in 1945. Some other participants here may have heard of or have seen Scribner shunts if you're as old as I am. When I was involved in training and first in practice, Scribner shunts were being used. And this is a silastic tubing inserted directly into the artery and vein, most commonly into the radial artery and to the cephalic vein at the wrist. This permitted maintenance of access between dialysis treatments rather than the antecedent separate cut down each time. So people would run out of vessels very quickly. So here's pictured 2 possible Scribner shunt arrangements. Eventually it was developed a technique to convert the Scribner shunt to an AV fistula. The Quinton catheter also was developed at the University of Washington, where Scribner worked. It has been used for acute hemodialysis since the 1980s, originally using a single lumen type. And some people here may have heard of single lumen dialysis, but the dual lumen catheters came out very soon in multiple configurations, and the tips were gradually improved, and eventually the implanted types were developed. Just for your historical appreciation, here's pictures of Brescia, Semina, and Apple. The standard wrist AV fistula is often referred to as a Brescia Semino fistula or Semino fistula, and that's Semino in the middle. But the one who did the surgery is never talked about is Dr. Apple on the right. These 3 men all practiced at the Veterans Hospital in Bronx, New York, and Dr. Apple, probably without any additional guidance, performed the first 14 patients and published them in 1966. When he did those operations, look at the left upper picture rather on this slide. He performed a side-to-side anastomosis between the artery and vein. And during my initial training, we were still doing that. And the only type of anastomosis currently in use, in regular use anyway, is the end to side, end vein to side artery anastomosis as seen in picture B here. The side-to-side anastomosis and the others all cause different problems, but still had some usefulness. Side-to-side anastomosis was easier to perform for some physicians. This is a picture of some mock plastic arteries when used for training surgeons, general surgeons, in this case, general surgery residents in Latane, Kenya, who sewed these anastomoses during practice sessions. An AV fistula is the simplest type of vascular surgery. It's usually superficial, involves 1 anastomosis, although an AV graft requires 2. It usually does not require general anesthesia, and in the States, this procedure is most commonly done with local anesthesia along with a nurse anesthetist or anesthesiologist or KRNA in Kenya to give intravenous sedation if necessary. This type of surgery requires careful attention to detail, so successful AVF surgeons often have OCD. The goal of these classes and the goal of this slide presentation is to teach people two basic surgeries, an end-to-side wrist fistula and an end-to-side antecubital fistula. AV graft use, we want to minimize in East Africa, and it has more practical application where the grafts are readily available and where interventional radiology maintenance of these grafts, because they are certainly more expensive to maintain and require more manpower, woman power, than may be available in many locations. These are some of the instruments we use during AV fistula surgery, and so my students learn some new instrumentation, many of which are adapted or directly used from eye surgery. For example, bona colta forceps, which are used to handle the artery and vein during the anastomosis, is named after an eye surgeon. Similarly, Castro Viejo, this is the surgeon who invented this needle holder, who was a Spanish-American eye surgeon. And these needle holders are in common use for vascular surgery all over the world and are certainly used during AV fistula surgery. Little retractors we use to provide the vessel exposure. And these are familiar to some of my colleagues, but not to others. Vascular dilators, rigid dilators, not balloon dilators, are an important component of the vascular surgeons or AV fistula surgeons armamentarium. And a full set is 1 to 5 millimeters in diameter in 0.5 millimeter diameter steps. The flexible shaft is made of a silver alloy, so it's repeatedly reshapeable. And the use of these tools can help relax spasm in the vein. Bulldog clamps, we see two types here, but there are many types. This larger type can be used on the brachial artery. The smaller type, which has very gentle jaw pressure, is used on the vein to prevent back bleeding during the actual anastomosis. And a tip to my students is that the closed jaws of this smaller bulldog, Dietrich bulldog, named after a cardiovascular surgeon, the closed jaws also make a substitute for a vascular dilator. Heparin flush solution is used during this surgery in a dilution of 10,000 units per liter or 1,000 units per. The heparin tip needle is equivalent to a 3 millimeter dilator, and it's very convenient size because a 3 millimeter vein at the wrist is very predictive of a good AV fistula in my experience. We use a small plastic IV cannula if the vein is too small to accept a 3 millimeter dilator. Magnification is used by most, but not all surgeons during this type of surgery. I typically use 2-power magnification. I wear glasses and lose things. So an OptiVisor, which is inexpensive, is more expensive than loupes, which may cost $1,000. The OptiVisor or a direct magnifier of this type may have interchangeable lenses, but the working distance shortens directly as the magnification goes up. Working under magnification is something that the student surgeons have to become adapted to. Also, the Castro Viejo needle holder is a skill that they have to acquire. A big part of the training is how to pick the arm, right or left, and how to evaluate the veins. And this is probably as important as how to do the song. My golden rule is to use the arm with the better veins. It seems like it makes sense, but the patient always wants to use their non-dominant arm. And the non-dominant arm is selected only if everything else is equal. If they have equally good veins, predictive of a good fistula in both arms, then use the non-dominant arm. You have to have adequate arterial supply to make a fistula in any extremity. Even a scarred, paralyzed, or fixed position arm can be used, provided the position of the arm during the dialysis treatment would be suitable. Not all would be, but it doesn't automatically rule out the use of that arm. Examining the arm veins requires good light and a tourniquet. I prefer a rubber band type of tourniquet rather than a glove. Letting the patient's arm hang down off the side of the cart or having them in a sitting position is really important, and also taking a few minutes of time. When you put the tourniquet on and first start looking at the veins may not want to show themselves as much as if you patiently wait for 2.5, 3 minutes with the patient slowly opening and closing the fist. And it's amazing, including using gentle slaps on the arm, and the vein responds to show itself. It's really amazing how much will show after 3 minutes rather than after 30 seconds. Ultrasound does have a role, an increasingly important role. The ultrasound is done preoperatively routinely now in the States. That's not practical in all settings, and it may be practical in your setting. If you have an ultrasound technician and you're going to start doing a fistula surgery, it may be possible to easily educate a educated vascular ultrasonographer to simply size the veins for you and determine segmental patencies. Preparing a one sheet of paper, pre-printed form, greatly facilitates this sort of exam. We found some use for ultrasound during our recent fistula camp, but basically the clinical exam was of much more importance. We used it as an adjunct, and that's what I recommend it for. It's very helpful in the obese patient. The ultrasound can help by disclosing unsuspected occlusions or to avoid a surgical exploration for a vein that does not exist. Also, once you have an AV fistula, if it's giving a problem, an ultrasound exam can show the cause of high venous pressures, a swollen arm, why the fistula is failing to mature, and other problems can be investigated with this exam. The Sonosite, some of you have access to, so this is a high quality ultrasound machine, but very operator and experience dependent. Many emergency rooms in Kenya now have this facility. So even though you can palpate the vein at the antecubital fossa, it's very helpful to know if that's a solidly thrombosed vein from long ago versus a usable vein for an AV fistula. We found the rubber band tourniquet and the surgical skin marker to have endless use during our recent camp to teach people to make AV fistulas. We found that they had to have a prep solution for the surgery that did not remove the marker. And the students were taught to mark the artery, vein, and the proposed incision. If the patient is seen in advance of the surgery, days or weeks or months in advance, they're told to save that arm for any future venipunctures or IVs. Of course, after the fistula is made, the same is reiterated along with no blood pressure cuff measurements from that arm. Here's some of the wrist anatomy. Deep anatomy at the wrist is really not applicable to the AV fistulas, but the location of the veins, which is highly variable, are the main point. Some patients have damage to the sensory nerve twigs during a wrist fistula, causing a triangular area in the thumb web dorsally after the surgery. This is not too bothersome to most patients. It often, with time, regrows some of that sensation. This slide is shown to the students to show the looking back and forth between the right and the left slide, the main cephalic vein being brought down to the radial artery, which is always subfascial beneath the fascia, is the main job of the fistula surgeon attempting to make an AV fistula at the wrist. That's their job. As far as determine the arterial supply, I teach the students to go back and forth, right to left. You certainly don't want to use an arm with a feeble pulse. Any feeble pulse at the wrist rules out the possibility of a wrist fistula. So it's not, there's no sense in examining the forearm veins in that situation. In older diabetic people or type 1 diabetic people, you can run into pipe stem quality arteries at the wrist, which are very difficult, sometimes impossible to sew. Sometimes knowing the blood pressure is important. If you feel the pulse examination is feeble, then knowing the patient's systemic pressure at that time is an important thing in your decision-making process. Deciding the arm arterial supply, which one has the better, is as important as looking at the veins. So many of the patients we met only minutes before their surgery, oftentimes an hour or two or the day before. And we marked their veins. So many people had marks on the arms on both sides, and we explained to them what the surgery would be like in simple terms, and also explained to them that there were risks or any kind of surgery. I taught the students the moniker BioSyn to remember the points to count, to cover during the discussion of risks. That is bleeding, infection, occlusion, swelling, and nerve injury. If you routinely, as a surgeon, explain those things and then answer the patient's questions, you'll have a happier patient, happier family, and be able to sleep easier at night. This is a picture of my wrist, and I have great veins, but they don't particularly show up very well. Lighting is so important, but there's a very typical average good cephalic vein and the position of the radial artery, which is relatively constant, marked on an arm. Now the proposed incision has been added. Because we are seeing many patients in a short period of time, and they had marks sometimes made by our examining team on both sides of the arm for the proposed surgery always had an arrow pointing to the incision that was favored. So this was actually part of our decision-making process, going on with drawings in the patient's arms by going back and forth. The patient and the families, I believe, don't perceive us as know-nothings. They perceive us as careful by going back and forth in weighing our decision. This is my preferred incision for wrist fistula at an angle. There are alternates. Longitudinal incisions can be used, single incisions, double incisions, but our favorite and the one that I taught was the angled incision. And all of these things can be used by good surgeons. We talked about some of the complications. It is important for the patient and their family to realize that the fistula can block anytime. There's at least a 10% primary failure rate of AV fistulae, and any dialysis patient with a functioning AV fistula realizes that their surgery, that their fistula may fail someday or require maintenance someday. Swelling and nerve injury, we talked about a little bit. For antecubital level fistulas done at the elbow level, it's much more important to discuss also the possibility of, and this is often in the same rodeo as a nerve injury for the patient and family. If they develop an ischemic hand, it would often present as tingling or anesthesia or fingertip pain or hand weakness. These things are hopefully unusual in experienced fistula surgeons. The truths about AV fistula occlusion rates, I looked up in order to make this talk, and I found that in good hands, presumably the Mayo Clinic has good hands, during the fistula first era in 2011, in 317 consecutive AV fistulas in 293 patients, there was a 37% primary occlusion rate. I must tell this group that I'm not sure how they defined primary occlusion rate. In other words, it didn't make it through the first week, the first night, or didn't make it to any dialysis. So I'm not sure how they define that, because I haven't read the primary literature myself for this paper. However, it is interesting to note that the first person to do this, Dr. Apple, whose picture you saw earlier, in his original 14-patient series, only 2 occluded primarily for a 14% primary occlusion rate, which is highly admirable. Occlusion rates in the community are commonly reported as somewhere between 30 to 70%. Continuing along with the steps, an IV start, if necessary for the procedure, is done in the opposite hand. This is usually done for intravenous heparin, and if intravenous antibiotics are to be given. Intravenous antibiotics are always given for an AV graft, but in East Africa and AHN patients, a single shot of intravenous antibiotics is part of the routine favored by the medical team. Positioning on the proper type of table and operating room is important. And once again, making sure that the washing surgical prep doesn't remove the markings that you're so heavily dependent on as an AV fistula surgeon. A surgical timeout is done to make sure we're dealing with the correct patient and the correct side of the body. Then the line of proposed incision is infiltrated with a 25 gauge 1.5" needle, which all of my students love very much. We did use anesthesia, lidocaine containing epinephrine. This might be heresy to some people, but it cuts way down on skin bleeding and does not influence spasm of the vein in my experience. The skin incision, it's most important that the surgeon realizes that the vein is always going to be close to the skin incision. After the initial skin edge incision, the use of the surgical cautery was minimized as veins are very prone to spasm. Exposing the artery and vein using one incision, using the Adson pickups to expose the vein and artery, using suitable retraction, and being very gentle with the vein. We handle the vein with a silastic vessel loop as much as possible to avoid repeated pinches with the forceps. Even tiny vein and artery branches can bleed during the surgery, and 4/0 silk ligatures without use of clips or direct cautery of branches is favored. A real godsend is papaverine. Papaverine applied topically to the vein during the dissection course, during the course of the dissection, relaxes the vein incredibly, and it makes inoperable veins operable. And this is most dramatically shown during our 2-week AV fistula camp. Papaverine is now being used for erectile disorders, and so the price of it has gone up and the availability of it has gone down. But Dr. Vincent and I have located supplies of it, and we had a satisfactory supply for our recent students. During the surgery, the artery and vein are mobilized in the vessel loop in this way, going around the vessel loop with a right angle clamp, taking care not to go through a branch on the way around. Sounds pretty easy, but there are problems with learning this process and problems with doing it even for the most skilled and experienced surgeons. After the vessel loop is around the vessel, it can be used to provide traction rather than pulling with a metal instrument. Setting up for the anastomosis, the vessel loop around the proximal vein, partial heparinization. We use full heparinization if the anastomosis is being made to the brachial artery, and partial heparinization if it's being used for the radial artery. The vein is divided and brought end to side to the place of proposed arteriotomy. Prior to opening the artery, the vein is divided and tested with heparinized saline, dilating the vein proximally if needed, and repeatedly dropping papaverine on it. 1 vial of papaverine can go and be spread around among 5 different patients having AV fistula surgery on one day. I teach the students to avoid dissecting with the cautery, which many general surgeons and vascular surgeons do, because the vein goes into spasm more. Small spreads with the scissors, ligate even the tiniest radial artery branches, and suture ligation of the distal vein. Arteries are any named artery is always under a fascial layer. Even the superficial temporal artery, which you can see beating on the side of the head during movie actors, still there's a fascia covering it. The radial and brachial arteries are always located between 2 delicate concomitant veins. We try to separate those from the artery, preserving them if we can, passing the vessel loop only around the artery. If the person has hairy arms, which we don't see too much in Kenya, but in Italian Americans, it's clipping and shaving is often necessary. Very important for the surgeon to learn to respect the vein position when making the skin incision. The little bracket at the bottom of this slide shows the portion of the radial artery being exposed. This slide also shows a clip being used on one of the branches, which some surgeons favor, but I do not. And so you don't see a big dissection field like this during AV fistula surgery. You're looking through a window about the size of the bracket at the bottom. The vessel loop can not only be used to handle the artery and vein, but it can also be used to occlude the artery instead of a vascular clamp. Using a single loop technique on traction is the most gentle to the artery, more so than double looping it or applying a vascular clamp. Opening the artery looks like an easy thing to do when you see a big picture like this, but remember our radial arteries may be 2 to 3 millimeters in diameter. So the use of the 11 scalpel blade has to be done very carefully. Damaging the back wall of the artery at this step is what we would call a bozo no-no. The scissors, often an eye scissors called a Westcott scissors, or in this picture, an instrument called a Pott scissors is used to extend the arteriotomy. How the surgeon holds the number 11 blade is important, and how they handle it, and to make sure that they have in fact entered the lumen and not gone into the wall of the artery. This can be difficult in atherosclerotic patients in smaller vessels. After the slit is made in the artery, it is converted to an elliptical arteriotomy. All surgeons do not do this, but I favor it, and it makes the job much easier to do to actually sew the anastomosis. So curved pair of scissors, tiny scissors, Westcott eye scissors, and other varieties are used to remove an elliptical wall, as you see in the upper slide here. The lower slide method is not advised. Surgeons who choose to sew to a slit arteriotomy usually have to use pull-apart sutures called stay sutures. I haven't seen it studied, but perhaps someone in this group knows about it. If there is a comparative study between elliptical arteriotomies and linear arteriotomies for the AV fistula. I'd love to know that information. The end-to-side anastomosis, which is done for 99% of AV fistulas, can be done in multiple ways technically, but the single suture tie the heel method is what I teach and what I've used for most of my AV fistula experience. So it's easy to teach, it's easy to learn, and it's harder to get goofed up. And we're going to go through this step by step. This may be boring to some of you. This may be very interesting to some of you. The parachute method of anastomosis means that you put several sutures before drawing them tight. This is more time-consuming and very prone to dangling and tangling of sutures and confusion of the assistant and sometimes the surgeon. I don't recommend it, but do also look at this slide for the labeling of the words heel and toe of the anastomosis. What is called the conduit here is the vein, and the target vessel is the artery. And we use the terms heel and toe constantly as we're teaching and learning this surgery. This is typically what is done during AV fistula surgery in the modern era. The vein is divided and tied distally. Then the vein, which you just saw being transected, is back cut. A small scissor is used to enlarge the lumen, as you see in the pictures, converting the target vein to a larger opening that makes it easier to sew and less likely to stenose. Another way that we teach the students is to watch for a branch in the vein in the right place. This became known during our camp as the trouser method because of the legs of the trouser. The two branches are tied. The branch itself of the outflow vein is preserved, and then the pair of trousers is converted with the pictured cut using a tiny scissors into a large spatulated hood, much easier to put into place on the artery than either one of the branches or a hood made from the vein further up. General surgeons often need to learn the lathe rest principle during the learning of AV fistula surgery. The hands often rest on the table. Sometimes the hands rest on one another, or the instrument, the fine instrument being held in one hand has to be steadied with the fingers of the other, because we all have a tremor when we're doing very fine motion. The lathe rest principle is named after a a British engineer and inventor, and it is used every day in workshops using metal and wood lathe. Notice the man here in the picture. He's using a sharp tool to make a chair leg or table leg, and his tool rests on a lathe rest while he's manipulating it against the workpiece. The translation of that to surgical motion is the left index finger shown in the slide in the picture on the right. The Castroviejo needle holder or the small scissor is resting on the finger to minimize tremor as the vessel is modified. Now, once you have the vein and artery lined up in this fashion, the end-to-side anastomosis, so-called single suture tie the heel technique, is the following. Use 7-0-proline double-armed suture. Double-armed means there's a needle at each end, and inside out on each vessel is the suturing technique used with the Castroviejo needle holder. Then a knot is tied. This is what it looks like when the knot is tied, and the students are taught to tie the suture with unequal lengths, roughly 2/3 and 1/3. The important step of passing the longer suture behind the vein hood is taught, and then the longer suture end needle enters through point 1, outside in on the vein, very close to the corner knot, and then inside out on the artery. So you're coming outside in on the vein at point number 1 and going inside out on the artery, point number 2. The back wall of the anastomosis is then continued in this fashion. The assistant must maintain traction on the suture throughout the anastomosis in order to have a hemostatic result. It is fortunate that blood is thicker than water, but we don't want it to leak regardless. When one suture is being used, the other needle is kept out of the way on a mosquito clamp, not a metal mosquito clamp, but one that has rubber shod jaws. What is that? This shows some very fine polypropylene suture being clamped in rubber shod instrument. This is the only way to clamp and keep a suture length like this at bay without damaging it. If you tag the suture in this fashion using an ordinary metal hemostat, it will fracture the proline. Very fine proline fractures easily, and students are taught not to use any metal gripping instrument on the proline. So the suture is continued in the direction of the arrow. There's the rubber shod hemostats. And during the suturing, sometimes the surgeon takes separate bites on the artery and the vein. Sometimes the needle goes through both the artery and vein with one push. That's called a blast. Blast it through. Sometimes the needle goes through the artery. You see the needle and then through the vein. This is called a visual blast. Actually, the direction of sewing is almost always vein first, then see the needle, then go through the arterial wall. That would be a visual blast. The idea of seeing it, separate bites, gives you the best visualization of where you're placing your needle. Sometimes that's needed, sometimes not. The more separate bites you take, the longer the procedure takes. And there's times when a push or blast through both walls is actually the safest. Now, in this picture, you see that the suturing has been continued around the tip, and you're headed back toward the heel of the anastomosis. The students are taught to continue 1/3 of the way down the front wall and then switching needles. Now the picture shows sewing again from the heel forward toward the toe with the other remaining needle. That's the one on the shorter suture length, and coming 1/3 of the way towards the toe. That leaves, let's back up one slide, please. That leaves 1/3 of the distance open between, on the front wall. Back wall is completed, and the front wall is 2/3 completed. Prior to finishing up, there's several steps. The artery must be flushed antegrade and retrograde, and the vein must be flushed with heparinized saline. I teach the students to always test the vein with heparinized saline to make sure it's accepted before the artery is ever open. We repeatedly have taught the students that prior to opening an artery, you always make sure the patient has been heparinized. The 3,000 or 5,000 units, and to make sure that the vein has been tested. If you test the vein and find out that it's not accepting heparinized saline freely, it will not make a good fistula. So in this picture, you have the first knot and the finished knot, and you're ready to open and test the fistula. Tips to make it easier are to feel the outflow vein, the hood at the end with a fingertip, and a thrill can often be felt immediately. That is a buzzing sensation. A vein that accepts a 3 millimeter dilator will mostly always work well, whereas a 2 millimeter diameter vein will often fail. Final hemostasis is very important, and the students are taught to trace a stethoscope circle on the completion dressing with a marker so that they can auscultate and the nurse can check if they wish. Now this is, we've got, 10 minutes left, so I'm going to quickly go through, the steps now of making the end-to-side anastomosis. I'm going to quickly go through some of the antecubital anatomy. You see the veins there in a muscle-bound individual. If you look at the left hand of these three pictures, this is my favorite incision, the white line, the white curved line for the favorite antecubital anastomosis for the cephalic vein. The basilic vein on the medial side of the arm is a deep vein and must be transposed to make a useful fistula in most people, not everyone, but most. Whereas the cephalic vein on the lateral aspect of the antecubital fossa is in a suitable subcutaneous position to be directly fistulized with an anastomosis at the antecubitus. All the dotted lines you see are a variety of incisions that different surgeons use for this technique. And here on the left, we see some of the veins, the cephalic, median antecubital, and the basilic vein. You see the position of the brachial artery. During this fistula camp, we saw someone whose brachial artery was located completely deep to the median nerve, which I cannot remember seeing before. I'm sure I've encountered it, but I couldn't remember it. It's a very unusual circumstance that we ran into. Making AV fistulas at the level of the antecubital fossa, you don't have to use the cephalic vein itself. The median antecubital vein feeding the cephalic works out fine. It's important, once again, to make sure the vein accepts heparinized saline satisfactorily. And now on the brachial artery, you have to start worrying about hemodynamic steel and limiting the size of the arteriotomy. 6 or 7 millimeters is about the longest that you want to go. A 6 millimeter long arteriotomy will usually not steel and a patient develop hand symptoms. However, if it's only 4 millimeters long, it may be very difficult to sew. And so there's a compromise point there. Some females have a very small brachial artery, and these may be more prone to steel, and the arteriotomy must be sized accordingly. It's important for the student to do the anastomosis at the elbow, that is the antecubitus, not really the elbow, with the arm completely extended. If someone has rested a little pillow under the hand to make the patient more comfortable, perhaps, that could provide an anastomosis under tension, which when the patient straightens their arm completely could tear. So we splint the antecubital level AV fistula patients in full extension overnight. If there's any significant oozing, then we leave them in the splint 2 to 3 additional days. It's important to tell the people to be able to get their hand to their mouth by day 4 or 5. Elderly patients can stiffen up pretty quickly. If there seem to be dual brachial arteries, this is usually a high takeoff of the radial or ulnar artery. Either one can be used for the AV fistula, generally the larger one if you see them both during the exposure. And we teach people about the problems that they can run into right during the surgery. A small avulsed arterial branch, a single bleeder from the anastomosis, the entire anastomosis bleeding, or oozing from the soft tissues. And we have approaches to all these things based on experience. Perhaps needless to say, if the patient's anticoagulated, that usually has to be dealt with in some fashion. Clopidogrel patients are typically stopped 1 week in advance, 2 weeks even better if their medical condition permits it. If there's no thrill in the hood of the vein when finished, this happened, This happened during our camp, and the students learned how effective the following technique was. Intraoperative Doppler is not available to many rural areas. So an excellent technique. There's a pulse in the vein, but not a thrill. And there's no intraoperative Doppler sterile probe available. So the OR team stays sterile and the wound is closed, and the surgeon listens through 2 layers of gauze with a non-sterile stethoscope for the bruit. If it's present, then the team, then the surgeon removes the stethoscope, takes the gauze with him or her, and then the team puts the dressing on. If you find that the vein will not flush, you haven't opened the artery yet, but it won't accept heparinized saline flushing. The vein is obstructed. You were fooled. Don't open the artery, use another outflow vein, move somewhere else. It won't work. Now you find that the vein, another problem is heparinized saline goes in, but only with very high resistance. This means an outflow vein stenosis. Usually it's best to go ahead with the planned AV fistula. Sometimes this can be dilated intraoperatively, may need IR attention afterwards, but often works out very well as the vein dilates. Various problems can be encountered when the patient returns to clinic: no bruit, oozing and serous drainage from overuse of the extremity. The patients are taught to elevate and rest the limb for 2 weeks, using it only for eating and drinking during that time. Here's a patient with swelling of the wound area, and another patient with the entire limb swollen after the AV fistula. So most of the nephrologists understand the cause of these things. The first one, if the wound is very swollen, it's usually overuse of the arm immediately post-op. If the whole limb is swollen, then an outflow vein stenosis is invariably present. And if interventional radiology is available, then the outflow tract can be dilated or stented. Mild cases can be managed with compression wraps. Sometimes these can become so disabling that the fistula should be ligated. Venous transposition procedures proximally have also been described. Various other things that the new fistula surgeon can find themselves in, and some help with approaching these problems. And this is just a little picture of the kit that I described to determine patency in the operating room. And this is how the wrist fistula is auscultated, only going through 2 layers of gauze, and the surgeon removing it. If there's no bruit present and the vein accepted heparinized saline freely during the procedure, and the surgeon is certain of that, then the wound can be reopened and something found. Sometimes there's a band or kink in the proximal outflow vein that the surgeon was unsuspecting. Advice to patient going home: we've talked about this a little bit already. In Rochester, New York, low-dose aspirin is used in all these patients. In LA, California, no patients get aspirin. So there's no good data on this. We've talked about this at this meeting already. And Dr. Vincent and I decided the fistula camp patients would get low-dose aspirin for 2 weeks post-operatively. Very important that the dressing the tape is not used circumferentially until the fistula is mature, and probably not even then. And we gave printed instructions to the patient, all the things that you tell your fistula patients: blood pressure cuff, venipuncture, IV, wristwatch, circumferential tape. All right, we're pretty close to time, but I'd be happy to have any questions, or perhaps we have some disagreements, but I hope you have been a wonderful audience and quiet. So I thank you for your attention.
Thank you so much, Doctor, for the nice presentation and extensive one. So now I would like to welcome Dr. Lloyd Vincent to take over for discussion and winding up.
Thank you, Doctor.
Are there any questions, any comments from the panel? Most welcome. It'll be wonderful, actually. Dr. Francis Fura, Dr. Amar, Dr. Jonathan, Dr. Robert, anybody, any questions, any suggestions, any comments, it'll make it much more interesting as well.
Dr. Lloyd, thank you very much for this interesting talk. My question is, how likely is it to revise a fistula that has gone wrong? Is it possible to revise it afterwards? after it has been used? Thank you.
Sure. Well, it's a very good question, and it's a question that we run into all the time. And the answer is, it is possible, but it depends on what is wrong with the fistula and what the patient has to work with. If there's a stenosis of the anastomosis, but a basically good outflow vein, and there's no interventional radiology available, then the simplest thing to do is repeat the anastomosis 1 inch higher on the artery. You know, no patient likes to hear that something could go wrong with their fistula, but we all know that it's quite possible. And we tell patients that their fistula may occlude, that they could be the unlucky 1 in 10 or more, and we don't try to minimize it. If you have a failure to mature, either you've selected an inadequate vein or there's a stenosis of the anastomosis. Interventional radiology friends are, instead of the vascular surgeon competition, if they're working as a team and friends, in the community for hemodialysis patients, they are complementary, not competitive. But the answer to your question is, it depends on what's wrong with the fistula and what they have to work with. Sometimes, if the fistula is limping along, sometimes it's the best thing to do is to use it while you make another one, then the patient doesn't have to have a catheter. If you make another contralateral one. Aneurysms on the fistula often develop in patients who have had their fistulas for a long time. Typically, we revise those with grafts or ligation in the past. Now, more and more, these aneurysms are being plicated, and the hemodialysis schedule can be continued using the very same ipsilateral access.
There's one question from Dr. Ben Lomatao. Thank you, Prof, for the nice talk. The Brasco Semeno invented the first AVF side to side. Why is it now changed to end to side? What is end and what is side? What is the side? Could it be opposite or has to be this way only? Why?
That I can answer that question, and I thank you for that question, because it shows me that I wasn't being a good enough explainer. The end of any vessel, artery or vein, means you have transected the vessel on purpose as part of the procedure and are using the transected end, most often transected in an angled fashion, for the anastomosis. Side to side is sort of self-explanatory. You're bringing the side of the artery to the side of the vein. Why did they use it that way at first? At first, it was a novel idea, and they didn't know what would work. No one had thought that an AV fistula could be used for this. So it's technically easier for some people to perform a side-to-side anastomosis, so it was thought. And to answer your question, the problem that the side-to-side wrist fistula caused, and it wasn't consistent, but it was common, was the hypertensive thumb syndrome. This means that the outflow from the fistula was going in both directions, not only up the arm where we want to dilate the channel, but it was also causing hypertension in the veins of the hand, and it was causing a painful thumb in some people. And I can remember as a resident and young attending surgeon taking people to the local anesthesia room and simply ligating the distal vein at the wrist where it's going to the thumb, and then the pain would go away. So eventually people started doing side-to-side fistula because they knew how to sew it already, and then they would immediately, during the procedure, tie the vein going to the hand. So eventually it became end to side because they were creating a functional end to side by ligating that distal vein during the original procedure.
Yeah, he wants to know which is end and what is side. Is the vein artery? That's a question.
Okay, you okay, end to side means end vein side artery. End vein side artery. If we could, Lloyd, is it possible to go back to the slides?
Yeah.
way back near the front. The picture speaks 1,000 words.
Yeah.
I'm going back in my slides too. It's right after Scribner and keep going. Yep. It's called Too Much Material for 1 hour.
This
By
one?
the way, there's now next. Good. This picture. Thank you, Lloyd. Okay, here's the answer to the question. Slide B is the only one in modern day use. The end vein is on top. So even though it's angled and it's, we call that spatulated, it's the end vein to the side of the artery. Whereas the picture at A on the top left shows the side to side. That was their original anastomosis. So imagine the patient's thumb is to the left of the picture A, and the patient's arm is to the right. So what they did was at the end of the procedure, once the fistula is working, but before they closed the skin, they would put a silk ligature around the vein going left towards the thumb as a prophylactic ligature to prevent the venous hypertensive thumb. And then that converts it into a functional end vein to side artery instead of side vein to side artery. By the way, the picture at D, lower right, is the operation that was developed to convert a Scribner wrist shunt to an AV fistula.
So the next question is from Dr. Mazhar. Thank you for the comprehensive presentation. Do you recommend isotonic exercising to assist in maturation of the fistula? Isometric.
That's a very good question. We always recommended it, but I was never aware of a study that proved it had any value. But we would teach, people would just develop something to say to patients. And I'm not sure, after over 35 years of doing this, I'm not sure that it helps the fistula develop faster, but it might. And so it's a nice thing for a patient to do. And it's a good exercise, if nothing else, and it probably increases blood flow mildly through the fistula, so it don't hoit. So we used to tell them to squeeze a rubber ball or a sponge 10 times, 3 times a day. Other people, they carry it around with them squeezing. I know certain dialysis suppliers put their name brand on a sponge with finger grips on it, and they would hand them out at a dialysis unit, et cetera, et cetera. If anybody's aware of a study, I've never looked it up. Maybe there is such a study, but I'm not aware that it's been proven. We did recommend it.
Thank you, Dr. Jerry. So the next question is from Dr. Kakai. Any comment on longevity of side-to-side versus end-to-side anastomosis?
I'm not aware of any data. I wish I could give you something solid there. I don't know about a comparison there. I think that the end to side is actually easier to do, but it's a matter of training. Neither one is hard. The problem with B, that's the one end to side, end vein to side artery. The problem with that operation, the students have to look at this very carefully, is once you transect the vein, it can become twisted. If you have a quarter turn, or certainly a half turn, 180 degrees in the vein, the fistula will often occlude because of that. It may tolerate a quarter rotation, but not 180 degrees. Whereas the side-to-side anastomosis, it's always set up properly so that it cannot rotate. I'm not aware of a study comparing.
This next question is from Dr. Dominic Raphael. Thank you for your presentation. How do you, I think the question is fistula complicated by a Steele syndrome. Could you explain?
Yes, there's a second hour to this talk, actually. I think we cover it a little bit there, but it's an important thing to know. Basing hemodynamic Steele means S-T-E-A-L. The fistula is stealing blood away from the arterial supply to the limb provided by God. So not all the artery blood in the natural arteries ever reaches the distal limb. It's being stolen for the purposes of enlarging the fistula and making the dialysis machine and the nephrologist happy. Seriously, that's where the word steal comes from. So the treatment of it can be, sometimes it's so serious that the fistula should be ligated. The presentation of the ischemic symptoms in the hand rarely occur after a wrist fistula, except if the wrist fistula becomes very large after 12, 14, 16 years of functioning. I have seen hemodynamic steel based on that, and where radial artery fistula had to be dismantled because of ischemia and high flow through the fistula. But immediately post-operatively, virtually it doesn't occur in the wrist fistula. Oh yes, it's been reported, but most people can tolerate ligation of their radial artery, not only having a fistula there. It is possible for fistula flow to be so large that can actually pull blood out of the hand, and that is part of the reason it is called a steal. But from a practical standpoint, the new fistula surgeon does not have to be worried about if the anastomosis is based upon the radial artery. However, the pitfall is making the arteriotomy too large in the brachial artery at the antecubital level. People often have a larger vein at that level, ready to accept flow, and they make the arteriotomy a little too large. They're so happy with the result afterwards, and immediately in the recovery room, the person is saying, "Why are my fingers tingling, doc?" Or the next morning they're saying, "How come I can't feel on some of my fingers?" Pain in the fingers, numbness in the fingers, not the hand, the fingers, is always due to fistula steal, not due to any nerve injury by the typical fistula surgeries. I hope that's a good enough answer for now, but I'd be happy to talk about steal more. Most tingling should be tolerated and is often self-limited, but true digit anesthesia in a new fistula, I'm in favor of ligating the procedure, ligating the fistula and immediately reversing the ischemia, shutting down the new fistula rather than doing something complicated like the drill procedure. Some of you know about the drill procedure, which is distal revascularization and interval ligation of the fistula. And so that's a more advanced topic. It's a very longer, sort of more complicated operation in sometimes quite ill individuals.
Next question is what from Dr. Judith. What do you, thanks for the talk, what do you do to patients whose new arterialized vein is swollen, dilated, or having an aneurysm? How much longer can you use it?
Oh, okay, very good question. An aneurysm in a new fistula would be unusual. Now, we're not talking about grafts. Now, we're talking about fistula. If you can have a true aneurysm of the vein. You can have a true aneurysm of the vein that was not known about. The vein has never been subjected to arterial pressure before. Veins can have aneurysms. So if you have an aneurysm appear fairly suddenly after a new fistula, that's something probably best attacked directly, electively on a non-dialysis day by plication of the vein. Those veins, not always, can be plicated and the fistula saved. Aneurysmal development through the course of months and years of AV fistula is quite another matter. We all know that repeated puncture at the same site can weaken the wall of the vein in such a way that two big bumps develop or multiple aneurysms develop, or as the vein elongates and it becomes serpentiginous, some of these S-like sigmoid areas can become so large that they become dangerous. The use of the fistula is ideally to try and develop the so-called rope ladder technique so that the puncture sites are spread out rather than what I call one site-itis, which means either the nurse, the dialysis nurse, the patient, or both are in cahoots to keep puncturing the same sites because it's easy, or because the patient insists, or because the nurse successfully got in there the last time. So There are different kinds of aneurysms. The more chronic aneurysms, the danger sign is when the skin overlying the aneurysm becomes blistered or shiny. That's an impending rupture. Most ruptured aneurysms in a AV fistula, of course, can be stopped with a blood pressure cuff inflated on the arm, but the more sensible approach is for the patient to place a finger on the bleeding point and call for help, because the fistula can often be salvaged in that circumstance. Putting a blood pressure cuff on the arm during the time of transport of a hemorrhaging fistula can lead to loss of the fistula. Of course, if it saves the patient's life, by God, it's worth it. But the fistula can often be saved if the patient keeps a cool head. Ideally, these aneurysms are dealt with electively prior to anything catastrophic occurring. The shiny skin is the sign of danger.
The last two questions. One is, what causes the arm to swell in the older AV fistulas? How do you treat that? Again, Dr. Judith. And the last question is, how do you manage a fistula associated with a high output heart failure? So the first thing is swelling of older AV fistula arm. How do you treat that?
Okay. Let me answer the second one first. The high output fistula, where it's putting the patient into heart failure, I've run into that only a very few times in decades, and basically ligating the fistula is a very safe and effective thing to do if, in fact, the fistula is the cause of the heart failure. If it's suspect, people may not know for sure. So converting the patient to catheter dialysis to C and then building a new fistula may be the safest thing for the patient. So you eliminate that as a factor. It's hard, probably impossible to adequately test the fistula closed and still try to maintain it to see if the heart failure improves. It's not going to improve immediately. It's going to take some time to know that. And ligating the fistula is the only practical approach there, in my opinion. I'm sure somebody has developed another approach. As far as the question dealing with swelling onset later on in a chronically mature fistula, as fistulas continue to age, flow can continue to increase. So a venous stenosis may be present from a proximal catheter, perhaps a subclavian catheter or other problem in the proximal outflow veins that you can't see. And it is not a hemodynamic problem because of the relative degree of stenosis versus the flow rate in that arm. However, as the fistula continues to age and flow rates continue to increase, that balance may tip. And now you get sufficient elevation of venous outflow pressures that the arm begins to swell. Usually you'll have a clue with that because of your machine alarms being set. But you know what I mean there. But it can occur because a stenosis, which may be stable, may become a relatively significant stenosis relative to an increasing flow rate. The other thing is a stenosis can slowly worsen too. So any of those possibilities or combination.
Sorry, Jerry. Next question. I'm sorry to trouble you. Can we take two more questions?
Sure, as many as you want.
Okay, thank you. So again, from Dr. Dominic, in a patient with a permanent AV fistula, patients with permanent AV fistula have increased risk of congestive heart failure due to increased more left to right shunting. How often do you recommend evaluation of cardiac functions after permanent fistula?
You know, I'm going to play stupid here. I would say if the patient has a cardiologist, that's the best person to ask. I don't have any direct way of determining in any given patient whether the fistula is causing heart failure. There are situations where a patient has a huge arm fistula and you rest your hand on it. It's very apparent that the flows are extremely rapid. And then that patient's in congestive heart failure. Well, that's more likely than a guy in congestive heart failure with a 6-week-old wrist fistula. You know, I'm just making a sort of a silly example, but I would say the cardiologist examining that patient might be the best one to know if there is one involved in the care. Otherwise, it may come down to ligating a big proven high flow fistula. People with high flow fistulas, their nephrologist usually knows it, and the patient usually knows it, and their dialysis nurse usually knows it, because they get the new nurse always on that fistula. But seriously, some of these things can develop tremendous flow rates, but we just don't see it that often.
I think the final question from Dr. Mazhar: what is your view on the use of a bottle cap on a ruptured bleeding fistula to control bleeding before definitive management?
Okay, tell me that word again. The use of a water cap.
A bottle cap.
Now, what is that?
Dr. Mazhar, if you want to clarify yourself, please unmute and talk. What is your view on the use of a bottle cap? I mean, the cap of a bottle, I guess, on a ruptured bleeding fistula to control bleeding before definitive management.
I think I know what they're talking about. I'm guessing, but in front of me, I have a bottle of Coca-Cola right now. And there I'm unscrewing a plastic cap that's about 3/4 of an inch in diameter. I never heard of this before. It sounds like an excellent idea. You either with the finger, you press it over the hole, or maybe you even can, in certain circumstances, strap that on. You know, the best thing is if somebody is, once there's a strapping on something, even though it's potentially lethal, the hole in the fistula, once there's a strapping on, attendants pay less attention to the person. Whereas if something has to be monitored during the procedure, I bet they're talking about what we would call in the States a bottle cap. So you put a bottle cap over the hole and press on it. I'm only guessing that that's what the questioner intended. Sounds like a good idea to me. I've never heard of it, but anything, it may be more acceptable to the patient or their family to do it that way rather than pressing a finger.
Yeah. So, Mazhar, I hope your question is answered. If your mic is working, you can always talk. No problem. So I think we've come to an end of the session today. It is a wonderful session, Jerry. Thank you so much for letting us go through this. I mean, taking us through the whole of the AV fistula, the surgery, the complications, how it is done. And it's a lot of information for us, the nephrologists, especially the youngsters who are actually, looking into, hearing you talk about the old, the practices that went on and how it's changed to the current, the AV fistula that we do end to side. So thank you very, very much. And I think before we conclude, I've got to thank Jerry so much, because what he did over the last 2 weeks was coming down to Kenya and working with 6 of the surgeons from 3 different hospitals, over 30 AV fistulas that were successful and with no failure at all, I would say, no failure at all. 30 successful AV fistulas between 6 surgeons who now are independently able to do AV fistulas. So you will have fistulas being done at Chogoria, at Kijabe and Latrine. And that's really wonderful. So a lot of people will get access to AV fistula from all these places, and I'm sure this will be a huge program in the future. So Jerry, I think hats off and for this wonderful work that you have done, and I'm sure we will see a lot of work coming out from Kenya now, and I think we will have a whole discussion on fistula camps and capacity building in AV fistulas in the coming, I think on the 28th of April. There are more camps that have been occurring in Rwanda and in Tanzania. So we will have all the surgeons club together and then discuss on this, vascular access, capacity building. And I think I really look forward to that for different views and opinions. I'm grateful to you, Jerry, for this wonderful exposition, for all the work that you have done over the last 2 weeks. Really hard work. And I'm sure all the surgeons would be extremely grateful and thankful for having had the opportunity to work with you. Thank you, Jerry, once again.
You're very welcome. It's been my pleasure. To God be the glory. Lloyd and his partner Nick have set up a wonderful opportunity, and I do think it's the interposition of divine intervention that has set this all up, and I'm so pleased to be part of it. God bless you all.
Thank you very much, Jerry. Thank you so much.